Sawadee krab, everybody. My name is Midnight. I am the Executive Director of APCOM. And it's a very wet weather here in Thailand, in Bangkok. I hope it's nice the weather where you are and that you're also keeping well and safe. Welcome to the Monkeypox and Community Readiness webinar for Asia and the Pacific region. APCOM in partnership with PEPFAR, USAID and EPIC, supported by WHO and UNAIDS. Thank you for making the time for joining us in this really exciting discussions on what's happening globally and what's going to happen or what's being done in our region currently to tackle monkeypox. So this session has been informed by so many of the community groups in the Asia Pacific region. We sent out a survey and you responded for us to do this starting monkeypox webinar, but we hope that this will be a series of others to come. The objectives of this first webinar, we are looking to share latest information on monkeypox globally and in the Asia Pacific region, to discuss barriers to accessing monkeypox information, prevention and treatment, and to consolidate information and concerns amongst the populations here in the Asia Pacific region. And then we have very varied speakers and very knowledgeable people to share the experiences. But what we like to also make sure that you have an opportunity to partake, discuss issues and ask questions. Please do use the Q&A function at the bottom here of the Zoom box. Type in your answers and our speakers will also be able to answer any of your questions that you may have. And please feel free to also use the chat function as well, if you prefer that. If you're not speaking, you are on mute, and then your cameras is off. So please raise hands if you want to speak, if you really want to speak, and if you can type. So try to make sure that you're getting as many opportunities to ask questions as possible to our speakers for this session. And to go through the agenda quickly, we'll have opening remarks from Dr. Pimpanita Sanyakun from USAID Regional Development Office here in Bangkok. And then we'll go over to Andy Seal from WHO in Geneva. And then we'll get some sharing discussions from country response in Thailand from Dr. Opat Putjaran of the Thai Red Cross. And then we'll get a community person surviving COVID, Harun. And then we'll get a community organization who's been doing the community outreach, Kronos Kwok from the Action for AIDS in Singapore. And all through that, you'll have time for follow-up questions and answers. And then from APCOM's team, we'll have some sharing from Nikki Suwandi, who's going to be giving us an update on what has the results of the survey that we sent out earlier is. And a bit of sharing also from Siripong, or his nickname is APCOM Campaigns Officer, on what our campaigns has been on the monkeypox in Thailand. And then we'll end with Dr. Heather Marie Schmidt, who is from UNAIDS WHO Regional Advisor, particularly on pre-exposure prophylaxis, about moving forward. And hopefully we'll be able to cover all this within the next hour and 20 minutes or so. And as I said, this will be a first of many series of webinars to come. And if you have any questions, please do feel free to reach out to us and ask questions as you go along. And without further ado, I'd like to invite for the opening remarks, Dr. Pimpanita Sanyakun, who is HIV Deputy Team Leader, Office of Public Health, USAID RDMA in Thailand. Over to you, Dr. Pimpanita.
Thank you so much, Kun APCOM. Good afternoon, good morning, everyone. It is my honor to join distinguished guest, Andy Seal from WHO, Dr. Opat Putjaran from Thai Red Cross Emerging Infectious Diseases Clinic Center, Harun from UK, Kronos Kirk from Singapore, Dr. Heather Marie Smith, UNAIDS and WHO Regional Advisor for PrEP, and Nikki, Kun Siriprong, and Kun Midnight from APCOM, and other honor guests. My name is Pimpanita Sanyakun. I'm Deputy HIV Team Leader of the USAID PEPFAR team, Office of Public Health at the USAID Regional Development Missions for Asia. This monkeypox, sorry, Monkeypox and Community Readiness webinar is critical for community partners. On July 23rd, the WHO Director General determined that a multi-country outbreak for monkeypox infections is past public health emergencies of international concern. As of September 28 or yesterday, there are over 67,000 confirmed cases of monkeypox in 106 countries, which the vast majority of infections being reported in countries that have not historically reported monkeypox. Multiple countries across the Asia-Pacific region have reported cases. The U.S. government welcomes the recent declaration by the Director General of the WHO and views it as a call to action for the global community to stop the spread of this virus. Infection diseases know no borders, and the monkeypox virus is no exception. There is no only response to a global outbreak. Countries must act not only within but also across borders. Ending the monkeypox outbreak is a priority, and we need to work with other governments and international partners to share technical information to aid others in their responses and continuously assess to identify areas where we can be the most effective. Communities have important lessons to share, and that will help to inform prevention and risk mitigation efforts. The U.S. Agency for International Development, or USAID, is coordinating with our international partners, including the governments of low-income and lower middle-income countries affected by the outbreak, and WHO and other multilateral organizations and local partners to better understand the outbreak as it evolves and to inform both national and global outbreak responses. USAID also leverage or redirect their appropriate existing programs, including the Global Health Security Program, USAID President's Emergency Plan for AIDS Relief, or you know as PEPFAR, and maternal and child health programming towards the global monkeypox response. USAID is pleased to support this webinar as an important means of sharing information and experiences to assist communities in preparation to rapidly detect and contain monkeypox viral infections in high-risk communities. Among other priorities, risk communication and other community education and engagement activities are essential, including for high-risk populations such as men who have sex with men, members of the LGBTQI community, and people living with HIV. We acknowledge that partnership is the underlying elements of successful infectious disease efforts. I see this commitment today as technical and financial partners, as well as regional community-based organizations, come together to learn about and discuss monkeypox epidemic control. I especially want to thank the leaders of our community partners, WHO, the UNAIDS Regional Support Team, EPIC, and APCOM for their support for this collaboration, with community-based organizations to provide critical services for key populations. USAID is honored and grateful to be able to join this webinar and congratulate you on this initiative. Thank you so much ค่ะขอบคุณมากค่ะ
Thank you very much, Dr. Pimpanita. Thank you so much for your partnership and also underscoring that the partnership will be important for us to take forward, particularly involving the community groups. For next speaker, I'll turn to Andy Seal, who is an advisor in the WHO Department of Global HIV, Hepatitis, and STI programs, all the way from Geneva. Thank you so much for joining us early morning your time. So Andy will be talking about what we know so far around monkeypox globally and also in the Asia Pacific region. Andy, over to you.
Thank you so much, Midnight. Good afternoon, colleagues. Good morning, good evening from wherever you're joining. It's a real pleasure to join you for this session, and thanks to the organizers. I would first like to also acknowledge that we have other WHO colleagues online for this, including colleagues from the region. So it's great that they are with us. Dr. Keo is with us from the regional office. He's our new senior advisor for HIV, viral hepatitis, and STIs. And so we're certainly keen to explore how we can strengthen our partnerships with communities moving forward. So what I would like to cover today is offer an overview of monkeypox, some of the trends globally and regionally, cover what we know about symptoms, modes of transmission, prevention, treatment, and care. Dr. Pimpanita has already made a fantastic introduction, actually, and I'll be re-emphasizing and building on some of her comments. So I'll also cover some issues around HIV and monkeypox, the role of communities, which is critical, and an indication of what's next for the response. So let's start with what is monkeypox. So this is a viral zoonotic disease, which means it's transmitted largely from animals to humans. But then once humans have the disease, it can also then be passed on from human to human. It's related to smallpox, although it's less severe. And with the eradication of smallpox in the 80s and the cessation of vaccination programs, we've seen monkeypox emerging as one of the most important orthopox type viruses for public health concern. And we have seen outside of the areas where we've noticed this animal-human connection, which is largely in Central and West Africa, we've seen that also spread to small community outbreaks from human to human, and also related to travel. So we have seen over the last decades some small outbreaks. But this current outbreak that started this year is certainly the largest that we've seen outside of the African region. So the current global situation is that we've now had cases reported in all WHO regions, all 6 regions, and across 105 member states. So this is data from just, I think, 2 days ago. A total of 66,343 confirmed cases, and now we have 26 deaths reported. And these are confirmed cases. And so as with all communicable diseases, we anticipate the true figures are likely higher because of undiagnosed cases or asymptomatic cases. And you'll see on the epidemic curve that we did notice a global peak. So it does seem to be some level of global slowing, but it's really important that we look at the next slide to see what's happening in the regions, because it's all very different. So you might remember that the European region was really the region where, you know, we had a lot of cases taking off quite rapidly in May and June. And then we saw a shift to the Americas. So if you look at the numbers on the sides here, we're talking about cases in the thousands. And the Americas, so while Europe seems to be slowing, the Americas remain strong in terms of how this epidemic is playing out. And again, numbers really in the thousands. For the other regions, including Africa, where we know monkeypox is also has been there for many decades, and through this animal-human connection, the numbers are still relatively low compared to Europe and the Americas. Similarly, when we look to Southeast Asia and Western Pacific region, it is a little bit like the Eastern Mediterranean region, smaller numbers. Western Pacific has higher numbers than Southeast Asia. And I know for you, Asia Pacific, I think straddles our 2 WHO regions. So it's important that we look at both of those data sets. But it's still an issue of concern. And as the previous speaker noted, diseases like this do not respect borders. And the trends that we saw in Europe and the Americas could quite easily take hold in other regions without due public health attention. These are just a few examples of how the epidemic has been playing out, which gives us some indication of what might happen should you see a significant outbreak take hold, for example, in Thailand or in China or in Australia or any of the countries from your region. So we're seeing, in countries like Canada, Germany, and France and the UK, a real slowing of the epidemic. But then you look at the US, it's still fairly robust. And then countries in South America, Colombia is on here, Mexico, Central America, also very high. So sustained levels of the epidemic. And again, we're constantly looking into what we know about this, so we can understand what the dynamics are from the actual epidemic. As has been noted, we know that the large proportion of cases, particularly in the first months of this outbreak, were reported among men who have sex with men, linked to sexual contact, often linked to gatherings or events where there might be several sex partners, multiple sex partners. But that trend has slightly declined as we've seen the epidemic move to other countries and regions. So we're seeing less reported cases among MSM. So it's still close to 90, it's between 85 and 90%. But it means that we can't exclusively focus our response on this group. We have to be constantly looking at the data and understanding what's happening. The graph below here, though, still tells us that the vast majority of cases are male. So part of this story might be that we're now also facing challenges where people are becoming infected in countries where it's very difficult for them to disclose their sexuality or their sexual histories. And so that might be part of this story. And again, when we look at the much fewer numbers of females compared to males, and we look at what was the context for the exposure here. For males, it's still predominantly party settings with sexual contact, and then we look at household transmission. So there's a level of intimacy around that personal contact. It doesn't have to be sexual, that facilitates transmission. For women, it's largely household. So the dynamic shifts somewhat. So smaller numbers of women, obviously, that we've been able to look at here because of the overall dynamic of the epidemic. But we're still seeing a small number of women also exposed through party settings, which include sexual contact. So again, this is data that really helps us understand what's happening and how we can respond. Again, data that really looks at proportion of cases with a reported symptom. We're seeing, the largest number of symptoms reported are linked to any rash, fever, a systemic rash, rash associated with the genitals, headaches, fatigue, etc. So there are a range of symptoms, and I'll say more about this shortly. But the most common is fever and some kind of rash. My colleagues in our epidemiology section at the Health Emergencies team are also trying to understand how well countries are responding to the monkeypox outbreak. So they've developed a policy and a response tracker, which really helps us understand, our countries, are we able to get data? And I'll explain what that data might look like in the next slide, to help us understand how well countries are being prepared. And so you'll see here that compared to Europe, which obviously has been, and PAHO, which is the Americas region, which has really had to deal with quite significant surges of the epidemic. CRO and WIPRO have smaller numbers of countries reporting cases, and also with policy indicator data. So the policy indicators really look at, do countries have a case definition in place? Do they have a contact definition to support contact tracing? Is there a testing strategy, a vaccine strategy? And then around vaccines, colleagues have really looked at both, a little bit like HIV, where we think about ARVs for PrEP and then for PEP, the use of vaccines that were developed for smallpox, either for general vaccination or post-exposure vaccination. And then the response indicators are then linked somewhat to that availability of, what does that response look like? What's the testing capacity in the country? How many tests have been performed? How many are positive? Are vaccines available, and are they given? So we'll try and dig out some of the detailed data for your region if that's helpful, and we'll do that through the WHO regional office and make sure that that data is available to those of you who are interested in this from an advocacy point of view. For modes of transmission, a little bit more. So as I've said, most commonly reported mode of transmission is through sexual encounters, but person-to-person contact can quite easily also facilitate transmission. So especially if there's contact with lesions or sores, noting that sores can be internal, they can be in the mouth or the anus. Questions are still being asked about, would it be helpful to classify a monkeypox as an STI? It certainly behaves somewhat like an STI, particularly for our communities that we're talking about today. It seems to behave in that way, but it's not exclusively transmitted through sexual contact. So again, there is also the possibility of contamination contaminated, bed linens and towels, etc., that can also facilitate transmission. We've had more examples of outbreaks linked to tattooing in Europe. And also, as I've said before, the exposure settings have largely been around parties, bars, and gatherings, particularly in the early stages. I think now that the trends have moved on, and any male-to-male sex can obviously facilitate transmission, especially if people are with new partners. There are some quite interesting data emerging around HIV and monkeypox. So where we've got data, we know that around 40% of the people who are reporting monkeypox infection are also HIV positive. And then actually a larger number where we have data, probably around 50%, are also taking PrEP as pre-exposure prophylaxis. So, but there is no link to the medication. I think everybody understands that. This is more about potentially, the profiles of men who might be attending parties where there is sex on the premises, and very often we know that people are quite keen to prioritize making sure that they don't either pass on HIV or that they are able to protect themselves from HIV. This is the main priority for this community. And so it's not really a surprise that a lot of the people who are becoming positive with monkeypox are using ARVs either for treatment or for prevention. There's a lot we don't know yet in terms about the relationship between HIV infection and the immune response. We've seen individual cases that have been quite dramatic, where people have had undiagnosed HIV and then they've learned their diagnosis of HIV at the same time as monkeypox, because the two things have really combined to ensure a fairly severe case of monkeypox, in fact. So those cases have attracted some media and research attention. In terms of the commodities that are available, we do have testing, vaccines, therapeutics, and antivirals available. These have largely been produced in the context of smallpox. Access is a big issue, so there's a lot of work happening now about trying to expand access, trying to really get studies pushed through to ensure that safety and efficacy are at the top of our list. We certainly don't do anything at WHO unless we're comfortable with the safety data. And so there are multiple trials underway. Yesterday I put just this little box on the bottom left here. Yesterday, CNN reported data from CDC that was shared in the US that is encouraging. We know that unvaccinated individuals are 14 times more likely to get monkeypox than vaccinated. So we're getting these RCT type trial data coming through now that help underscore the fact that vaccines can work. But there's no guarantee that you won't get monkeypox if you've had the vaccine. It's a little bit like COVID. You know, there are levels of protection, but there is no guarantee that you will not go on to contract monkeypox. A little bit about WHO's role. Essentially, it's really around coordination, providing technical guidance, and I'll say more about that shortly, and then supporting coordination of some of the key elements around infection prevention control, lab testing, etc., and data and community engagement. On this slide, you'll see a number of the community engagement guidance and public advice tools on the right here. A number of them are also available in Chinese. So we have a Q&A, a guidance for MSM, fact sheet, what you need to know. All of these are also available in Chinese and all the other key languages. On the WHO website, you'll find public advice on recovering from monkeypox at home. I won't go into the details of that now in the interest of time. Please feel free to access the web pages. Similarly, we've updated this. The public health advice for men who have sex with men goes beyond prevention. It also talks about what to do if a community member himself or herself becomes infected. So it really looks at roles that community people can play around monkeypox. Newly completed advice also for sex workers. We hope to have that up on the website shortly. And then just a few words about really the interface between science and community, because I think most of us on this call are from an HIV background, and we're well aware of the power of when science and community comes together. And we had some great sessions at the AIDS 22 conference in Montreal, where we saw a lot of activism and a lot of great science being shared. And we really would like to encourage more of those conversations. In Montreal, as with in most contexts, I should say, as soon as awareness around monkeypox reaches communities, do seem to see a trend of willingness to get the vaccine. We don't see huge amounts of vaccine hesitancy. Of course, we remain open to learning more from various studies and surveys. But there has been quite a strong focus on vaccines from communities. But we need to, again, as I said before, recognize that this is not a silver bullet. Stigma and discrimination, as with HIV, remains a huge challenge. We had a webinar last week. Again, Haroon joined me on that one. I really enjoyed that webinar. We really talked about what can be done from a healthcare perspective, and I think that's worth looking at. At global level, we also have a reference group. Midnight represents you well and Nikki on that. So thank you for your continued engagement there. And we had a really interesting dialogue with the DG earlier this month, and you'll see Midnight there in the middle of the screen. He came and really brought some really important Asia-Pacific recommendations and advice to that conversation. Key themes coming from communities really are making sure that we're promoting solidarity around the access challenges when we can, and really funding community contributions. So working, to make sure that we're deliberate about the community role, plan it, make sure it's costed and funded, and all of the fantastic partners who are engaged in organizing this webinar are already part of those discussions about how we can repurpose existing funding streams that might have been allocated for HIV or related work, and make sure that we're able to build on those, on the infrastructure that's already in place where it makes sense. And then finally, next steps for the response. WHO is strengthening its own response capacity. A few more staff members will be joining us in the coming weeks. Access will be a big focus for us, I think, moving forward, including for testing and for vaccines. Health worker training, similarly, a big focus. We will reconvene the Monkeypox International Health Regulations Emergency Committee, most likely later this month. they will review where we're at with the response following the declaration of a public health emergency of international concern, and we'll continue to focus on community engagement, of course. So I'd like to thank a few of the people that are noted on this slide and pass back to you, Midnight, and thank you again for this opportunity.
Thanks so much, Andy, and colleagues at WHO for not forgetting the Asia Pacific region, and also involving myself and Nikki in the global calls with updates on monkeypox. And of course, we look forward to continued partnership as and when this develops further as well, for us to be better prepared. Particularly, I think when data is coming through and the coordination with other technical and donors at the global level as well. Colleagues, attendees, if you have any questions, please use the Q&A function, because we are running a little bit out of time. But Andy, do please stay with us, because I think some questions will be coming through as we go to the next panels when we talk about the sharing some information discussions. So without further ado, I'll just pass on to the discussion on Thailand with Dr. Orpat Pujaran, who's the director of the Thai Red Cross, looking at what is Thailand doing around the monkeypox and how we getting better prepared, I suppose, and detect and deal with monkeypox in a more country context within Thailand. Thank you so much for joining us and sharing your experience.
Thank you so much. So thank you for invitation to give a talk today. So can I share my slides, because I have changed the version a little bit. Could you share my screen? Okay, thank you. Right. All right, thank you so much for invitation to give a talk today about the Thailand response to the current outbreak of the monkeypox. I just to emphasize that at this moment we are now seeing monkeypox in the way that different from what we saw in the past, because right now the clinical features of the monkeypox in 2020 in this era, in this year, is different from we have learned from the textbook, because we call the classic monkeypox in the past, but right now we calling this monkeypox as modern monkeypox outbreak. Why we call this? Because as you can look at the slide, the clinical presentation of monkeypox at this moment, at this outbreak, it has some specific features that different from the monkeypox in the past that has spread in West Africa. At this moment, the monkeypox may look like STI, sexually transmitted infections, and some of the individuals with current monkeypox disease have concomitant STI, and some of them might have co-infection with HIV, and some of them are PrEP users. So this is a thing that we should know, that the current monkeypox outbreak is now focusing on high-risk population of sexual transmission. So this is the reason why our country have to respond to these specific group of populations. So this is the slide to show that we have monitored the situation of monkeypox since May 2022, after we have learned that there was a rise of the cases in European countries and in North America, and then we also monitoring the spreading of the monkeypox in that regions, and then on July the 23rd, the director of the WHO just announced that monkeypox should be the public health emergency. And today, before the WHO announcement that monkeypox is public health emergency, we just had the first case of monkeypox in Thailand that confirmed by PCR in Phuket province. the first case of monkeypox in Thailand is not Thai people. Is the man travel from Nigeria? Is Nigerian man, and we think that he has monkeypox from his country and travel from his country to Thailand to work for his business. And after 1 day after the WHO announced the public health emergency of the monkeypox, Thai government also announced and elevate the surveillance system in our countries. And monkeypox is now under the monitoring of Emergency Operation Center of Thai Public Health Ministry, starting from July the 24th, 1 day after the WHO announced public health emergencies. And what we did, we start looking at the patients that may travel from the endemic countries. For example, some people may travel from European countries and from North America. We activate our surveillance system at the airport, and we have the monkeypox screening measures to cover our group of international arrivals. And we have the guidelines. We have both policy and response measures to tackle the monkeypox. We admit our suspected case in the hospital until the test result confirm the diagnosis. If the monkeypox is positive, we're going to keep that person in the hospital until the symptom resolve, and we make sure that there's no more risk of transmission to the communities. So the people with monkeypox will be hospitalized and stay in the hospital. And then we start providing the training for clinicians in healthcare provider and lab staff to recognize the clinical pictures of the monkeypox, which is a typical present. It could be a typical presentations. And right now, so far, we have 8 cases of monkeypox in our countries, and the government then expand the testing strategies to allow more testing available in the countries. In the past 2 months, the country is centered in Bangkok only. All people with suspected case of monkeypox, the sample will be shipped to Bangkok to have the test. Right now, we expanding our testing to nationwide level, and any regional hospital can test for the monkeypox. So this is the thing that we have done for expanding the testing to make the rapid diagnosis for monkeypox patients. And then we have our own treatment guidelines. Although we don't have enough, or we don't have tocilizumab for monkeypox, but we do have the other antivirals that can use for monkeypox treatment. So we also launched our first treatment guideline for monkeypox. And then we start looking at the vaccine. We have the vaccine for smallpox that kept for 40 years. And then we are now testing the immunogenicity of the vaccine that can use for smallpox prevention to use with monkeypox preventions. And then we are now starting to have sentinel surveillance in high-risk population, such as sexual health worker, sexual worker, and people who have risk for STI. So this is a thing that we have done since the beginning of the announcement of emergency situation of monkeypox in Thailand. So when we look at the epidemiology of people with monkeypox in Thailand, this is only 5 cases that we have made the diagnosis in my center. For the other 3, diagnosis was made at the other center. When we look at the characteristic of people who have monkeypox in Thailand, this is in combinations. Most of the people, most of them were heterosexual men and women. Only 2 of them declare as men who have sex with men, which is different from the other part of the world that monkeypox is more prevalent in men who have sex with men. But in Thailand, at this moment, most of the monkeypox infection occur in heterosexual people. And what we expect to see, it is very difficult to eradicate the monkeypox. So we expect to see the gradual increase in number of human monkeypox in Thailand. And disease might limit in specific population, for example, those with HIV infections, those people with risk for getting STI. And we think that the pattern of epidemic is similar to the epidemic of HIV infections in the past. So at this moment, in the Thai Red Cross AIDS Research Center, we are now setting up our strategies to help the government to make the diagnosis of monkeypox. We try to search the patient in our STI clinic and our STI network in Bangkok, and we start doing sentinel surveillance in high-risk populations. And we are now thinking about how to make the test more affordable. Right now the test for monkeypox in Thailand is like $80 per time per test, comparing to ATK for COVID-19, which is $2. So we think that if we have more affordable tests and widely available tests, we can make early diagnosis and can contain these people not to transmit the disease to the other people. So we giving the education for healthcare provider. We have the training session for healthcare provider about the monkeypox, and then we now preparing our antivirals for monkeypox patient in our center. Why the test is very important? As you see, when we look at these pictures are combination of people with monkeypox and without monkeypox. It is very difficult to make the diagnosis by using eyes. The test, for example, PCR, is very important for making the diagnosis of monkeypox. For example, this patient has herpes simplex infections, and this patient has monkeypox infection. When you look by eye, you cannot differentiate between these two patients, right? We need to have the test, and the test is very important to make the diagnosis, and the test is a key for early diagnosis and give the treatments and prevent spreading of infection to the other people. So we have tried, and we have many measures to contain the monkeypox in Thailand, but we still have some gap. We could identify the testing gap. We have the test that available, but the problem is the test is very expensive. We have the vaccine, but the vaccine that we are now preparing is the old version of vaccine. We don't have Genios, which is more modernized vaccine. We have the old version of vaccine that used for protection or prevention of smallpox. Those vaccine had very high rate of complications, so we need more safer vaccine, and we need high vaccine with high efficacy for prevention of monkeypox. And we still have the problem with stigmatizations. I have seen many patients who want to have the test, but after we told them that they need to give some additional information about themselves, about risk, they're afraid of we're going to share this information with the other people. So some of them deny to have the test because of afraid of stigmatizations. So we should emphasize that we all have same risk for having monkeypox, regardless of gender and race. So we have to work more on the stigmatization of monkeypox. This is the same thing that happened with HIV patients in the past, and we could identify some knowledge gap. We don't know pretty much about the characteristic of the virus right now and about transmission. I think this is my last slide. We are trying to do our best to contain the monkeypox, but we need more to do. We need to reduce stigmatizations, and we need to tell every people that anyone can get or pass human monkeypox, because this is human monkeypox. We need to prevent and treat monkeypox with humanities. I think this is my last slide. Thank you so much for invitation.
Thank you so much, Dr. Opat, for that very comprehensive presentation on what you're currently doing at the Thai Red Cross Emerging Infectious Diseases Clinical Center. And then as you were talking about, the stigma, we'll go on to next person who'll be talking about experiences of having monkeypox. But I also like to show you the there is the Q&A box that I think you should be able to answer for if you can also help answer those questions as well, Dr. Opat, please. There's a Q&A box. There's some questions for you. Yeah, great. Harun, I know Andy has seen you so many times, but I just want to say what great leadership in the community and really bravery to also ensure that your stories is also heard from the lived experience. But I'll let you tell the story. So Harun Tulunay is an HIV, sexual health and mental health advocate, and he's currently based in the UK. So thank you for waking up early to be part of this call with us as well. Over to you.
Thank you, Midnight, and good morning, good afternoon, good evening, wherever you are. Hello, everyone from London. And thank you. Yeah, I actually texted Andy the same thing. Maybe, you must be fed up with my story, but unfortunately, because of the stigma attached to this condition, not many people are willing to come forward to tell their stories. And maybe this is giving us something to think about, when we are responding to a condition. Like any condition impacted our lives, such as HIV or COVID, international response without any barriers and without causing any stigma is very important to end monkeypox, because we still can end monkeypox. And monkeypox showed us once more that inequalities and stigmatizing in the healthcare systems are still continue. My monkeypox journey was a very atypical one, according to my doctors, because how symptoms were presented and the severity of my case. It was very unusual. So it started with very high fever at the beginning of June. I would like to remind everyone that the first case in the UK happened this year in 2022, in the 7th of May. So in the beginning of June, we had very limited data knowledge about monkeypox. And I had over 40 degrees Celsius fever for 2.5 weeks. And I called emergency services more than 4 or 5 times to get help. Unfortunately, every single time I got an answer that I wasn't an emergency. So I was misdiagnosed 4 times because, like any other viral infection, monkeypox is being represented with rash, high fever, and because there was no clear communication or no information to the frontline workers, healthcare workers, the testing didn't come to anyone else's mind. The only person ever mentioned to me about monkeypox was my colleague actually working in sexual health. And when at this stage, when I checked the UK government's website, the only advice was, if you visited Africa, you may get monkeypox. So timely response is really important to prevent those kind of public health issues. And I have to say that a community response was the only response I could find. And for me to get testing, it took 2 hours because they need to clean the room every time. And they have to, take you in a separate ways to prevent infection. So the heavy burden over the healthcare, especially sexual health clinics, is really a lot, especially in the UK. And sexual health consultants and nurses have no additional support, and then just given another condition to take care of. And 3 weeks later, I had rash, and I was told that my HIV medication might stop working. And it was really scary because I never had any HIV-related issues in my life. And I came to a stage that, luckily it wasn't that, and I came to a stage that my throat was completely shut with lesions and I wasn't able to eat or drink, which luckily, then my nurses convinced hospital to take me in. And that was the best thing happened to me, because after 3 weeks, they put me on tecovirimat and the eyes just showed the first sign of healing. And it wasn't trialed before. and the trials just started recently, but I was ready to take it because I think personally that it really helped me. And then I heard that there was even a vaccine, but now the whole world is trying to access the vaccine, but there is only one company that is profiting from it, and we really need and giving all the profit to one company. And in Africa, just remember that there are still no vaccines or access to treatment available. So dealing with unknown is really much worse in a condition. But when I was finally diagnosed, and after 3 weeks, it was a relief that, you know, I was coming out of it. I was isolating at home. But then it struck me exactly the same history happened with HIV in the past. You know, unknowns, governments are responding late, people are name calling, labeling, especially LGBTQ plus community, exactly in the same way. So it showed that we really haven't learned any lessons from the past. So we really should be clear and communicate those things, that the past lessons with each other. And obviously I decided to go public because there were no information, and only information source was people who had it or voluntary organizations. And monkeypox is a condition that can be cured and prevented. It doesn't become a condition that you live all your life, but still there's so much stigma attached to it. And we really need to do something about that. I share my story, finally, I share my story, not to scare anyone, but to remind everyone that we don't know who may get it as a severe case. My consultants thought that I have a very robust immune system. My CD4 count is even more than people not living with HIV. So they were really surprised that I got it really severe. So if anyone had monkeypox, it is very important to be considerate and to be kind to each other without stigmatizing, because this is another condition that doesn't go away. There is a solution for that, but there is no solution, no cure, no vaccine for stigma. And believe me, stigma and negative feedback or backlash hurts more than the virus itself, and hurts more our community even more than any condition. Thank you very much for this opportunity.
Well, round of applause, Harun. Thank you for sharing your story, and to also continue sharing your story for everyone. I'm just wondering whether any community people would like to ask Harun any questions. I'll take that. I'll take that as more of a maybe no for now, but they can type it in. I'll do some of the all the presentations and then come back for some of the questions as well. So you can be prepared to ask some questions. Don't feel shy, please. This is a chance for you to ask some of the, even difficult questions. Harun is very open to answering anything. Yes.
Absolutely, please. You can ask anything.
Brilliant. Thanks so much. And then next, I just want to go through to Kronos Kwok, who is from AFA based in Singapore, to look at what have AFA has been doing around the getting the communities in Singapore to understand monkeypox and the strategies that they've been using and some of the feedbacks that they've received. Kronos, over to you.
Thanks, Midnight. Thank you for inviting me to speak. I would share a little bit about the community response that we put up at the beginning of the monkeypox spread in Europe, and then also outline some of the initial responses that we took as a community organization. So next slide, please. So we are quite fortunate that as a community organization, we have a number of STI and infectious disease specialists on our board who kind of alerted us to the early signs of outbreak in Europe way back in late May, early June period. And we recognized that there were increasing number of infections that were traced to sexualized contact, and symptoms of rash are reported on the genital areas. And people with symptoms started to present themselves at sexual health clinics. So For AFA, we actually provide sexual health screening at the community level. So it was important for us to take preemptive measures in preparation of the possibility of monkeypox arriving into Singapore. So by mid to late June, we began educating all staff and volunteers that worked at our testing services about monkeypox, and then also how to manage potential cases. We included screening questions about recent travel and potential exposure for all MSM clients that we see. Next slide, please. So I think Singapore saw the first monkeypox case sometime in early July. So as a response to that, by mid-July, AFA started to roll out social media posts and content to educate the MSM community about monkeypox. The content revolved around how monkeypox is transmitted, how people can potentially reduce their risk, symptoms, as well as where to seek care should they suspect they have monkeypox. In doing so, we found that it was important to strike a balance between ensuring that high-risk groups are properly educated on how monkeypox can be transmitted, but at the same time, fighting public perception that monkeypox is a gay disease. One of the things that we made sure that we want our messages to be spread as far as possible was we made content available in various languages. As you may know, Singapore is a multilingual society, so we had content available in various languages. And of course, we continued with our screening questions and surveillance at our community testing services. This was all throughout July and August. Next slide, please. As a follow-up effort to our social media content, we also conducted a webinar on monkeypox, which was attended by various community stakeholders. So we had representatives from various LGBT community groups and other community service providers. We also had healthcare professionals working with the MSM community. This include counselors, mental health professionals. And we also managed to reach out to some of the MSM saunas as well as MSM frequented business owners. During the webinar, we got clinicians to share more about information about monkeypox. We also shared our social media posts. And fortunately, our content was shared quite widely by community groups and other members of the MSM community. We also collaborated with other community groups to co-create social media posts and content. We even received some coverage on local media channels. So this all, went quite some way in helping us spread awareness for monkeypox. So I think in my next slide, I have some examples of the social media posts that we created. So next slide, please. Yeah, so these are some of the examples of the social media posts and content that we have created. You can see them on our Instagram page. If you would go to gayhealth.sg, you will be able to see them. So it is shared on Instagram, Facebook, Twitter. Yeah, so that's all I have to share.
Wow, thanks so much, Kronos. Very succinct and but full of information. And also, next I'd just like to welcome to kind of show about what you've been doing with in terms of Thailand for outreaching to the communities through online social media about monkeypox. Can you share with us a little bit? Thanks.
Okay. Hello and good afternoon. I'm Arm. Sirpong Sisha, the campaign officer for the APCOM. For what APCOM does about monkeypox, as of now, we have a platform called Test BKK that encourage our key population to get a blood test and generate demand for HIV prevention into innovation, as well as educating our followers about sexual health. Similarly to HIV or other STI, at the start of monkeypox, there was some stigma to the MSM that encountered monkeypox and believe that it would spread widely among MSM. But it's now proven in Thailand that monkeypox affects more than just the MSM. So we must continue to raise awareness and protect ourselves from monkeypox also. So for what test BKK can do is educate people through various channels, such as our website, Facebook fan page, Twitter, Instagram, or even in a TikTok, and all of which has roughly 81,000 followers. And I haven't even counted YouTube's 82,000 subscribers or so. Social networking platforms are inexpensive and simple to use. They represent a trend toward increased interaction in which people both create and consume content. It is possible to share story, create other contents, and have an impact on the digital community. And as a result, it is quite simple to educate and provide people with up-to-date information about monkeypox. So I create a batch of material for monkeypox to the test BKK channel, which we will conduct once a week and for a week. In the beginning, I began by translating an article about monkeypox from WHO, the one that is public health advice on monkeypox for gay, bisexual, and other men who have sex with men, into Thai and putting it on the test BKK website as the main article. And then I progressed to making infographics and memes as I learned the behavior of our follower with the 3-second attention theory, that we have to make them interested in our content within 3 seconds. So the material itself has to attract people to view it, as in the series of monkeypox content that I produce, it as an image. And in the future, in the next rotation, or if the monkeypox becomes more serious in Thailand, I would decide to make a short video or use key opinion leaders, or we call them influencers, to raise awareness about monkeypox also. And I would like to share the infographic and meme that we create. Okay, may I share the screen here, please? Okay. And for infographic, we create this infographic using as few words as we can and as many visual as possible to communicate important facts about monkeypox, such as the symptom, how it spread, what to do if it tests positive for monkeypox, and how you can help your community. And for other thing that we produce is memes. With memes, the aim of this type of item is to make it fun and easy to look at. Therefore, I then hilarious and educational things together to make it easier for our followers to learn and share our stuff. And there are various types of memes that we use, including this one, my face when blah blah, or another type that is before we know something and after we know something, and or into the message text box like this style, and the influencer memes like Drake, or in the style of comic panel, or using the image, and any other things that was trendy at that time. Okay, so the test BKK has the potential to promote a dynamic mix of education, contact people, and protest stigma because of the increase in user-generated content collaborated by people has the potential to impact mainstream media and policy without relying on campaigning organization. It is possible that we are more likely to shift our attitude in response to what our peers think than to what organization push us to think. And test BKK is their peer to talk, to listen, to share lots of things with them. Thank you.
Well, thanks so much. I'd just like to take a pause here because we've heard so many people talking, but I know that some people have been also typing into the Q&A, and I guess some people might want to do a live question. So I want to give maybe a few minutes here for those that want to pose a question to one of our speakers live. You just need to raise your hands, please. Let me see if we've got any hands raised. There's a hand raised. Oh, Kronos, you want to ask someone a question?
Yeah, I was
Right.
thinking of asking Andy a question.
Sure.
So at the beginning of the monkeypox spread, I think there has been some contention as to whether do we want to classify monkeypox as a sexually transmitted infection. I'm not sure what is the consensus now and how do the experts feel about that?
Great. Shall I go ahead and answer straight away, Midnight?
Yes,
Thank
go ahead,
you for
Andy.
the question. You're absolutely right. I think there are groups of people with very strong feelings on both sides of this. So there is a number of people who are very keen to see it classified as an STI, including people who work in the field of sexually transmitted infections. And then we see some counter arguments being put forward. I have to say that I personally sit somewhere in the middle. I'm fairly agnostic. I think the most important thing is that we just get the work done around the response. What WHO says at the moment is that it's clearly sexually transmissible. Now, a number of viruses that can be transmitted through multiple modes of transmission, for example, Zika, dengue, they all have the potential and they all can transmit through sexual activity. And monkeypox falls into that, definitely into that. I think there are ongoing questions in the research around whether monkeypox virus found in semen is really the route of transmission, which would really, allow us to say very clearly this is an STI or vaginal fluids. But because, again, we saw the photos from the previous speaker, there's a lot of genital rash, there's a lot of exposed skin lesions. So it's even when there's only one or two and people don't realize that they may have, they are infected, it's that close body contact that can be sexual or non-sexual that can facilitate transmission. So the short answer is, if in doubt and you'd like to follow WHO guidance, please talk about monkeypox as being sexually transmissible. It's a halfway house, I think, for us to get to a point where we may or may not, decide to classify this as an STI. I think we don't see any clear pros and cons at the moment. Again, anybody on this call, if you have strong feelings or arguments you would like us to consider, please do share, and I'll take that back to colleagues who are really thinking this through. Thanks.
Oh, I see Dr. Opas has got his hand up as well.
Yeah. I feel uncomfortable to say that monkeypox is STI, because when we talk about STI, it's look like that you can use condom to prevent it. So I usually tell my patient that it can occur through sexual activities, by kiss, by close contact, and also by intercourse, because there are some evidence has been shown that the virus may retain in the rectum or in the oral, in the mouth, so it can transmit during the sexual activities. But I am reluctant to say it is STI because it may be misconceived. Because if you want to prevent STI, you use only condom, right? But this type of infection, it can transmit to multiple modes of transmission. So it's be very careful. Maybe STI is one of the transmission, but not condom.
Yeah, if I can quickly add to that, I couldn't agree more. I think the condom messaging is really quite complex around monkeypox because, we're not, as Dr. Opas has just said, we are not promoting this as a prevention tool. Of course, when we're messaging around prevention options, we're saying partner reduction is a good idea, get yourself vaccinated if it's available. Condoms may protect against some of the more severe anal symptoms, for example, but they will not, as Dr. Opas has just said, they will not offer you protection from contracting monkeypox. And then similarly, people who have had a confirmed diagnosis are encouraged to use condoms for 12 weeks afterwards because of this possibility of onward transmission. Apologies for the little dog yapping in the background, if you can hear that. Thanks.
Thanks so much, Dr. Opas and Andy for that. So WHO says it's actually transmissible, yeah, and Harun decided to say he's on the side of non-STIs because there are also cases without sex that were transmitted. Harun, I have a question for you. I got a private message. I think the person wanted to ask you about, you talk more about the stigma within the kind of health systems, but how do you navigate in terms of actually stigma when you had monkeypox within the community? Was there any backlash? How did people talk about it? And what are you saying about like those that might say, oh, because you are sexually active?
Yes, thank you very much for the question. Normally when I do a presentation and I specifically copy and paste negative and positive feedbacks I received, and it keeps on happening every day. But because I'm working in HIV sector since my diagnosis in 2016, my skin is really thick, and I'm from Turkey originally, so my skin is really thick when it comes to stigma. But yes, it really hurts because there are comments like against me, imposing that I am, comments like I can't keep my pants on, or because I am gay and I'm living with HIV, so I deserve to have monkeypox. And, you know, some people are making it more religious side of the things because they don't, you know, accept gay people. So all around the world. What I do, I ignore those messages. But the most worrying thing is the stigma in the healthcare team, because I've been receiving messages from other people who had monkeypox in the UK, telling me that they were kicked out. They were just being put out of the clinic like a garbage bin because the healthcare system don't know how to handle an infectious disease. And if this happens in the UK, that many countries counts it as a well-developed country, I can't even imagine what happens in the rest of the world, you know, because there is no clear communication coming through. I personally think that dropping monkeypox on sexual health clinics only is a reason boosting stigma as well, because some people don't want to be seen in sexual health clinics. I met many people who are not following gay Twitter, I call it, but, you know, don't get the news. They don't know anything about monkeypox, and they are being stigmatized a lot. And what I do, I really ignore, because I'm relying on the science, I'm relying on the facts, and I just move on. I'm healthy, I recovered from it. Again, this is not a condition. We didn't do the same thing with chickenpox. We didn't ask anybody if they were, you know, worried about chickenpox, or, you know, so, but, you know, this is how I move through the stigma in the system.
Okay, thanks so much, Harun. Dr. Opas, just kind of follow up on what Harun was basically saying about ensuring that we're not just going to be concentrating on the kind of STI clinics. Is that one of the strategies for Thailand in terms of what you're doing for you know, the education for the health service providers in different settings?
As I told you that the target population is people with high risk behavior for STI. So we start our surveillance and our service at STI clinic. However, we do not use STI clinic as our name, the name of the clinic. We use anonymous clinic. So this is completely anonymous. So we try to make people feel comfortable to come into clinic, not disclose their name, and just come in and have the test for monkeypox. So this is the strategy that we are now doing. And also our government have received the grants to start doing the sentinel surveillance in high risk populations, such as male and female sex worker, to see whether we could see any infection among these populations.
Thank you. And then Kronos, is there like, well, you know, there's been really good news about Singapore looking at decriminalizing the homosexuality. And I'm just wondering whether this kind of like, the message is also changing the way that you're talking about monkeypox, and whether some of the messaging that you're asking people to go to the clinics, is it just for the STIs or run by the community, or are you also educating some of the facilities as well to look at symptoms and maybe refer to some of the more friendlier services?
I think in Singapore, we benefit from the fact that we are a small country. So whenever there are any medical directives, it's easily disseminated to all healthcare professionals. So from people in the government hospitals, private hospitals, even general practitioners, they all receive very timely updates on how they should either diagnose or even refer potential monkeypox cases, and it all funnels down to the National Infectious Diseases Center. So it's quite a simple process for us here in Singapore. In terms of awareness and education, it's still largely left to community groups like us for us to spread the awareness and education. It's covered a little bit on local media, but they didn't really spend a large or they didn't really focus on the fact that the cases were MSM and of that sort. So I think in terms of a public level of awareness, it is still low, but within vulnerable groups, like within the MSM communities, we have been ramping up our efforts to increase education for monkeypox.
Thanks so much for all the speakers. Any last question? We're going to the end, like 10 more minutes of the webinar now. Going once? Going twice? Okay, we have 10 more minutes. If you have any other questions, please use the Q&A box. As I said in the beginning, the webinars was actually done through a survey that we sent out to our communities, and I will list the list of the names of individuals, organizations that that were part of this webinar. We asked a few questions about what they want to see, going forward. So I'd like to invite Nikki to present that data.
Hello, everyone. Thank you so much for the time. My name is Nikki. I'm the Knowledge Management and Learning Officer with APCOM. I'm originally from Indonesia. It's really good to be here. As mentioned by Andy in the beginning, APCOM is really proud to be part of the community reference group on monkeypox. This group is organized by the WHO, and being part of this group, it leads us to realize that there's just very limited discussion about this emerging issue in our region, which is the Asia Pacific region. And that's the reason why, one of the reasons why we are organizing this webinar today. Prior to this webinar, we did a small survey, as we would love to hear from our community. We conclude and synthesize this survey at the beginning of this month. So let me just jump right into that. So when we ask about how have the participants addressing the issues of monkeypox in their community so far, 48% of them responded that 48% or almost half responded that they don't have resources to start to address the issues of monkeypox, and 37% responded that they have shared information related to monkeypox through their communication channels, including social media. One respondent mentioned that they had an internal session to discuss about monkeypox within their internal team. We asked what would they like this webinar to address. So the majority mentioned about basic knowledge and information related to monkeypox, including frequently asked questions and data. Also mentioned best practices to mitigate negative impact, putting plan into action or community-led response, including advocacy. And they also mentioned how to better communicate and educate, including issues of stigma and discrimination. And of course, a lot of them saying that the procurement of monkeypox vaccine is very important. And we also have a question, what kind of output that they would like to see from the webinar. So as expected, majority say that knowledge products or communication materials to be disseminated within their community. They mentioned about consolidated ideas for action or response, including statement or agreement, collective statement or agreement, guideline to advocate monkeypox related issues. They also mentioned compilation of case studies would be helpful, including successes and challenges from all around the globe. strong advocacy led by the community, petition for monkeypox vaccines, and of course, it's very important to note that funding support for community-led response would be crucial to address this issue. We also have a question, and this will be the last. We also have a question: what would they like to see happen in the region, in the Asia-Pacific region, related to monkeypox? So it's mentioned that clear messaging and information would be very important. And one additional note from a respondent saying that the information, it would be helpful for the information to be available in Braille or other medium for blind people or for other minorities. What they will also like to see in the region is a regional steering committee for this specific to this monkeypox issues. Collective response, including disaster risk reduction plan, effective monitoring mechanism, consultation or workshop to develop effective response, community preparedness, and vaccination. And as a side, we also asked what would they like to see happening in their specific in their country related to this issue. So one question is about the region, and then one question is related to the specific to the country. The response is almost the same, like the items that I suggested for the region, but it tends to be more specific, like sensitization for stakeholders, standard operating procedure to handle and control monkeypox issue, the formation of community advocates for monkeypox, and country-specific messaging and information in local language. So that concludes our summary of the small survey, and we really thank our participants, our community members who gave their invaluable insights. They provide really good suggestions and opinions, and we hope we can do something on some, if not all, these excellent suggestions to ensure concerted efforts and effective monkeypox community-led response for the community that we serve really taking place in the Asia-Pacific region. Thank you. Back to Midnight.
Thanks so much. I know it's really brief, but don't worry. I think everyone, you will get presentations from here, and if you are signed on to the APCOM's newsletter, you'll also get it through there as well. So don't worry, with the recordings and the PowerPoints, you will receive them. Harun would like to give us a bit of a tip on how to approach someone who has monkeypox. So Harun.
Midnight, following what Nikki said, communication is really important, but language really matters, like in any other healthcare setting. So, you know, some language used in prevention methods for monkeypox is really scared people and boosted stigma more than helping. So also the focused targeted communications is really important. So because we have to think that inequalities continue and certain racially minoritized communities are still out of focus when it comes to monkeypox response. So governments need to produce targeted responses as well as a wider community message, but it shouldn't be something like, don't let monkeypox ruin your summer. Do you know what I mean? So this kind of language really not helping. And we get lots of questions from scared people, but you know, 95% of the cases are mild, but this kind of communication just scares people and then just brings more chaos to the scene. So thank you.
Well, thanks for reminding us. Is how we communicate is also important as well, not just the what. Okay, we're coming to really the end, and in the beginning, Dr. Heather Marie Schmidt was saying like, "Oh no, I hope it's going to run over," so she doesn't have to say very much. But you still have your 5 minutes. I'll allow you to have that for the reflections and situations and moving forward. So Dr. Heather Marie Schmidt is from UNAIDS, WHO, a regional advisor on pre-exposure prophylaxis. Over to you, Heather Marie.
Thank you, Midnight, and thank you for the opportunity to say a few words on behalf of WHO to close. But I will keep this short because I do know that many people have other commitments. And we've had such an amazing discussion from all of the speakers today. I feel like there's very little that I can add that hasn't been already said. And so I really think that in the response to monkeypox, and this presents new challenges for governments and communities. We thought we already had enough challenges from HIV, and then we had COVID. Now we've got monkeypox. But all of these together are really being held back by inequalities, and these viruses together are exacerbating a lot of inequalities, and this is particularly true for our region. And so there needs to also, while we need to respond immediately to monkeypox, we also need to look at some of the long-term responses that help to strengthen our systems to prevent these from becoming such a challenge. So really looking at tackling those underlying drivers of inequalities so that we can have a successful response and are less at risk from emerging viruses. And so I think one of the key things that was really raised today was the importance of addressing stigma and discrimination and how much this is really compromising the response, not only to monkeypox, but it works equally for HIV as well as COVID-19 and other viruses. We know that stigma and discrimination and criminalization compound inequalities. They make people much more marginalized, and these impact on health-seeking behaviors and all aspects of service delivery. And this has an enormous impact, as we've heard today, on the response to monkeypox. In our region, laws that criminalize sex work and or the possession of small amounts of drugs exist in almost all countries. Several countries still have laws that criminalize transgender people or same-sex acts in private. And we have particular barriers that are of stigma and discrimination for young people who account for 1 in 4 new HIV infections and are generally less likely to seek healthcare and have access to healthcare. And so where there are laws limiting access, this can really impact and exacerbate existing inequalities and our response. So there are a number of other points that have been raised by our speakers today. And you know, this is a global outbreak. The vast majority of cases are in countries that have not experienced monkeypox previously, and monkeypox is now a global health priority, as highlighted by Dr. Pimpanita. And the importance of governments working across borders, because viruses don't recognize borders, and listening to the expertise of communities. This was a thread that was in all of the presentations today. And it's why we're all here. The importance of partnerships between communities, governments, and all sectors has been really demonstrated through the HIV response, through the amazing work done by communities to address particular vulnerabilities during COVID-19. And so really, again, we need to rally when it comes to monkeypox. Andy Seal from WHO provided an excellent overview of the monkeypox virus and its epidemiology, including that within the current outbreak, there are certain groups that are currently more affected, including gay and bisexual men, but that monkeypox is affecting a range of people, as highlighted by Dr. Opar. And Dr. Opar also highlighted the important advocacy needs. And these are things that I think are really important for civil society, but also for funders, for donors, and for other stakeholders, including technical agencies, to advocate for. And this is, making the test for monkeypox more affordable. I doubt Thailand is the only country to have this issue within our region, and making it more available to allow people to be diagnosed earlier and receive treatment. These kinds of things were huge problems in HIV and still are. So, the fact that we haven't overcome them, we need to do more. And making the vaccine available, and again, stigma and discrimination. And this theme was further addressed by Harun, who shared his own experience with monkeypox. Thank you for sharing that. and highlighting inequalities and stigma within healthcare settings adversely affecting the response, and raised a really great argument about not focusing monkeypox on HIV or STI clinics, which can inadvertently contribute to stigma and discrimination. And this really, again, this theme was emphasized by Dr. Kwok in his experience in Singapore. And what struck me was that delicate balance that needs to be struck between ensuring that groups that are at a higher risk of exposure are properly educated and receive all of the information that they need, while fighting this perception that it's a gay man's disease. And we know this struggle really well from HIV. And we know how wrong it can go. And so also the stigma and discrimination, we also know from the stigma and discrimination experienced by marginalized groups during COVID-19. So civil society have a really important role in this, but broader community efforts are needed as well. We cannot all be speaking to each other and not speaking to the broader community. And that's where, you know, governments and others have a really important role. And Dr. Kwok and Kun shared excellent examples of community-friendly communications and awareness-raising approaches, resources from gayhealth.sg and TestBKK that can be adapted for communities and other civil society across the region, and the importance of peers and a grassroots approach. So having those different levels of communication. And Nikki also really highlighted the importance of discussing monkeypox much more than we have. And I'm so grateful to APCOM for convening this webinar and allowing this discussion to take place with such a variety, and particularly with country level civil society. And the clear needs from civil society in country, and especially the importance of communication, language, and resourcing. So I'm going to just sum up, because I think this is almost my 5 minutes. But there are some key priorities in the HIV response in Asia and the Pacific, which are also applicable to monkeypox, to COVID-19, and to any of the other emerging threats of public health emergencies that we're going to face. And this includes service integration, making sure that we're not siloing the responses to STIs and HIV to one particular part, which can further stigma and discrimination and mean that people don't access the care that they need and aren't diagnosed for 3 weeks, as Haroon had the horrible experience of. Prioritizing the responses for key populations, making sure that those who would benefit most are still at the center and in those conversations, keeping communities at the center of the response, and ensuring resourcing for civil society, because civil society, really, we're expecting a lot from all of you. But we have this tendency, I think, to take it for granted that civil society is always going to be there. But civil society won't be there unless collectively we're supporting your role and valuing your role. So thank you for the role that you're playing. And implementing and continuing to really highlight the importance of implementing legal and policy reforms and laying that foundation, because without those longer term changes, we're going to have this conversation again and again and again, and nothing's going to change. So we really need to have a longer term plan for this. So there are concrete examples that we can do now, and that's equity to access in the monkeypox vaccine, in diagnosis and treatment for those who would benefit most, stigma and discrimination-free care. We can make strides in this education and raising awareness, and particularly making sure that that's in local language. So finally, what I want to say is I'm very grateful to APCOM for convening this webinar and for bringing together global, regional, and most importantly, country stakeholders who are going to be at the forefront of this response and many others to come. Thank you for the work that you're doing. And to all of our other stakeholders, particularly funders and technical expertise, you know, it's also a challenge to step up and to enhance our support of civil society who play such a crucial role. Thank you.
Thank you so much. I want to say thank you to all the participants, attendees, and you're staying a bit longer as well in the set time. So I really appreciative of that. Thank you, Dr. Hetemery Schmidt, and all the other speakers, Dr. Pipanita, Andy, Dr. Opat, Harun, Kronos, and from the APCOM team, not just Arm and Nikki, but we also have Trami, who's doing all the note taking, and Vanessa, who's doing the kind of the background work, and JJ for doing all the kind of like the graphics that you're actually seeing here. I just get the brief 90 minutes of fame here with you, but that's actually the whole team behind us in APCOM. And then as of course you have seen from Nikki's survey, all these other list of other participants who wants to take part and also want to be involved in the discussions and steering discussions, sharing the experiences. So we do hope that we'll be able to do more of these webinars as well in the future as monkeypox progresses, and then making sure that the tools and the knowledge is not just within the community, it's also being shared across the communities within the Asia Pacific region. Thank you so much, everybody, and have a good rest of the day in the morning or in the afternoon or in the evenings, wherever you are. From all of us here at APCOM in Bangkok, ขอบคุณครับ and สวัสดีครับ
Bye-bye. Thank you, everyone. Thank you, all the speakers.
Thank you.
Thank you so much.
Thank you so much. Thank you for your invitation.
Thank you.
Thanks so much, everyone.
Thanks, Midnight. Great summary, Heather. Thanks.